Dr. Omer, nice to meet you every time in the big conferences as usual. And we were yesterday in a panelist for DCB, and where are we now?
Yeah.
So what's your opinion?
So as you know, we had a very great session on DCB and new technology like bioadapter
Good.
dynamics, actually, and it went very well yesterday. It was one of the, I think it was the last session of the day, but it was very crowded. As you remember, yesterday we touched the evidence for using DCB in complex PCI and especially in CTO. And Şevket Görgülü gave very nice lecture about the result of DCB in complex scenarios, and he nicely showed his cases and
Right.
results of DCB. And after that, Dr. Bennett, he had a great really talk about again bioadapter, and he presented 2 years results of bioadapter, and then he showed that it's superior to Onyx stent in after 2 years, and he showed some examples as well. And after that, Daniel Benilman, he talked about hybrid approach, as most of them now these days do. Also, I like to do DCB only in my practice, but many of us do hybrid now, right? So
Yeah.
proximally implanted stent and mid or distal part DCB if it is diffusely diseased, or after CTO recanalization, it's nice to use some part DCB. And lastly, Abdullah, he had a great case on acute MI, and he showed us, although it was very traumatic lesion, but he treated DCB very nicely, and he showed the follow-up result. And also yesterday, if you remember, we talked about how we should prepare the lesion for DCB. I think this is one of the most important thing, how we should prepare it to have the excellent results after NC balloon, for example, or after DCB. And which lesion has to stand after NC, which one we could do the DCB. We talk about that, and also we talk about imaging, importance of imaging on DCB, if we need to use IVUS or OCT for DCB procedure. And we discussed that, it's not mandatory in many cases. It's not like stent, because stent we have, we have the risk of malposition, so we have to have size vessel precisely, not to have malposition or undersize, or we have to make sure our stent is expanded well, right? So we don't like underexpanded stent because of the stenosis or occult lesion. So imaging is always very important for those scenarios. But for DCB, we don't implant anything. We don't have any malposition problem, right? The only thing, you have a good lumen.
Yeah.
And if we have calcification, of course, we like to make sure we crack the calcium. Even we do DCB, to have a larger lumen, we have to crack the calcium.
So what I understand, Dr. Omer, from all of this, that we are now making the procedure simpler or making it more difficult?
No, after DCB, I think it's simpler, because if you remember, if you do, for example, barification, if you want to do DK crush, you have 8-9 steps, right? So
Exactly.
side branch,
Yeah.
crush, keys, rewire.
Yeah, maybe using the DCB is easier, simpler, and you can use it as you said, in the bifurcation, small vessels,
Yes.
distal vessels. There is that we were not using DCB, DS in the past. Now we have the DCB. But this DCB needs lots of preparation, imaging. Before we have one plan, one line to go with the DS, and that's it. Now, no, you may change. You cannot put just fix a plan from the beginning. I will use DCB and will not use anything else, or use dynamics and not anything else. Now you may change inside. Is that right?
Exactly.
While you are doing the procedure, using the image, you may change your strategy.
Definitely.
Is that right?
Definitely. So, and also let's talk about a little bit bioadapter. As you know, bioadapter is designed that the link will be released after 6 months. So cage became uncaged.
Yeah.
Means that the vessel can expand, and especially I think it's important for after CTO, because you know that in CTO cases or the patient with very high degree stenosis, like 99% stenosis,
Yes.
distal filling is not good. Yes, it's
Exactly.
underfilling long term.
Same
So-
as disuse atrophy, so it needs some
Exactly.
time to heal and to enlarge after
Exactly.
that. So when you put the DS, it will fix the size, it will
Yeah.
allow it to
Exactly.
enlarge in the future. But while Dynamice and DCB will allow for this.
Exactly.
So we have some development, but we need to pay for that preparation and more imaging and to be dynamic inside the case and to change it from one strategy to another one.
Exactly.
That's
I agree
great.
with you. Yeah.
That's great. That's great. So what did you plan from your? This we talk about something for about Dr. Omer and ask him about his. When did you finish the school? Were you planning to go for to be a physician?
You mean the high school?
To be a doctor after finishing high school? Did you? Was it your plan? I mean, you
Actually,
were.
yes, it was
You
my
like
plan.
to be.
To be honest with you, yes, but when I am in high school, actually, I had a plan to be doctor.
Ah, so
Yeah,
this is what
I
you
like
from the
to,
beginning.
In my high school book, we have yearbook, in hospital, in high school.
Yeah.
In that book, it's written that Omer like to be doctor.
And
So-
you were planning to go as cardiologist to be cardiologist.
Cardiology,
or-
no. The first I like to be physician, and then after that, after medical school,
Yeah.
I choose cardiology. I'm very happy to be cardiology.
This is not.
How about you?
So you have no. I'm completely different. I was planning to be an Air Force pilot.
Really?
Yeah, but
Wow.
my father and my mother actually they insist to go for a doctor.
Wow.
And every time somebody was visiting my father and asking him what Raed will be,
Right.
he used to tell them he will be a driver. I said no, I'm not. I'm not a driver of a
Pilot.
plane.
All right.
That's why they pushed me to go to be a doctor and then to be a cardiologist. Actually, it was not one of my plans.
But what do you think now? You're okay with to be
I'm an Air
physician
Force
or-
pilot now and doing CTOs.
Okay, very good. So, I think we have similar, because I think to be doctor, to be operator, a little bit similar to be a pilot, because the pilots, when they before the flight, they check everything, right? So it's
Exactly.
like us, we have to check many
Exactly.
things before we start the case.
Exactly.
So also we have trained, if
Yeah.
something goes wrong,
Yeah.
we should know what we should do. Like
Yes.
pilots. Pilots
Yes.
also train,
Yes.
if there is something wrong, they know
Yes.
exactly what they have to do.
Yes.
So I think
The pilot
not-
and the
not-
autopilot,
Right.
they have a common say, which
Yeah.
is garbage in, garbage out.
Right.
So the data you get from the beginning, if you didn't have it right, you will have a bad flight on the
Exactly,
trip.
exactly.
And this is what we do actually in our field in CTO. This is what we do. We plan very well. And we put the right data, so we'll have the right result.
Exactly.
They said CTO most of the time it fails. No, with experience, with good planning, I think most of the time it will succeed.
Yeah.
And this is what we see with Dr. Omer. It is really pleasure
Thank you.
to have you in every conference and to see you
Thank you.
always.
It's, yeah.
Omar,
Same as you. Thank you very much.
I
yeah.
appreciate it.
Thank
Thank
you.
you.
Thank you very much.
Thank you.